down the conduit, okay? And so Dr. Einthoven kind of came up with this Einthoven's triangle that we still use today. Our limb leads 1, 2, and 3, okay? But he didn't stop there. So what he noticed is that, you know, the electrical activity would create different things on his amplifier. So what I want you to do is I want you to think about, it's all about the perspective. So each one of these electrodes that we put on a patient's chest, okay, and Dr. Einthoven, what they did is he would take his wires, and he noticed that he got better tracings if he would put basically a salty gel on them, which is what we have on our electrodes today, okay? They're a much better product because they don't dry out as fast. And what he did is he put them to a suction cup. And so he would take the suction cup and he would attach it to the patient, and then he started to be able to get, by moving these things around, a lot of trial and error, but finally started getting what would be EKG tracings today. So each one of these electrodes that we place on the chest, I want you to think of them as a camera. When we look through the viewfinder of a camera, what are we seeing?
One direction.
Yeah, we're seeing something. We're seeing, you know, we can see it going away from us, getting smaller. We see it bigger and coming towards us, and then we make, you know, it shows on the film or in the video, right? As I'm walking towards that camera. So I want to talk just briefly about what happens when that viewfinder sees electrical current, such as his amplifier, okay? So this camera right here, the video camera, is an electrode. Right, so when we place patients on the cardiac monitors, each electrode that we place, we'll talk about placement, it becomes a camera at one particular point. And then of course the 12 lead, or the precordial leads we put on the chest also count as well. All right? So this is an electrode, it's a camera. Now I'm an electrical impulse, and I'm moving right towards that camera. So how is it seeing the impulse coming towards it?
Getting bigger.
Bigger and stronger, right? So the way that electrode and the amplifier is going to create that, it's going to make it come above the isoelectric line, just like we have right here. So here's a camera. It's looking up this direction. It's always looking towards the negative pole. And it sees the impulse coming right towards it, so it's going to make it nice and tall. Okay? So I'm coming right towards it. It's going to make me nice and tall. All right? What if I'm still moving towards it, but I'm moving this general direction? Am I still going towards it? But is it going to be as strong of an impulse? No. So I can skirt it this way, or even this way. I'm still moving towards it. It's still seeing the impulse. It's just not coming as strong. So depending on how it sees the impulse will depend on how it records it on the isoelectric line, okay, or on the EKG paper. So here's the camera, it's looking, but the impulse is not moving directly towards it. It's moving almost to, you know, a little deviated from it. It still sees it, but it's not going to make it as tall. Okay? Here's a case where the impulse, the camera's here. It's looking up this direction, but it really can't catch it coming towards it or going away, so it almost barely makes it there. Almost like biphasic, which means going in two directions. So there's a lead that we'll talk about that you're not going to really see much because it's almost electrically silent. Okay? Electrically silent. Now this same camera is looking at me, but I'm moving this direction from it. How is it going to record me on paper? Yeah, so it's going to make me go below the isoelectric line. I'm moving away from the electrode. All right? And the same thing applies. If I'm right here and I'm moving this direction, it's not as strong as if I'm moving this direction, okay? So it's not going to drop me as far down. Does that make sense? It's all on the camera and how it sees the impulse coming. All right, so let's go back to the work of Dr. Einthoven and get into this lead 1, 2, and 3 style. All right. So what Dr. Einthoven did is he came up with Einthoven's triangle. So we're going to see if this makes sense to you. So typically in our limb leads, leads 1, 2, and 3 are also known as bipolar leads. Bi meaning two, polar leads. One negative, one positive. Okay? Now on my mannequin here, I put my standard limb placement. Now, Dr. Einthoven believed that at the time, everything that he did had limb leads on the limbs. So he had them on the wrists and down by the ankles. Okay? And we still use those to the day. What's the downfall of having your arms with electrodes and your legs with electrodes?
It's not going to be its strongest impulse.
Well, it's going to be strong. There won't be a change with that, but
And the mobility, you know, can't use your hands and legs.
well, I can use my hands, but if I use my hands, what will that do?
Someone distort the view.
Yeah, I'm going to create artifact.
Yeah, it's a lot more.
Ugly, lots of artifact, okay? So through the years, we've said, well, you know, if we're going to be watching patients in the hospital or whatever, or transporting whatever, well, we need to bring them up to get them off so that people can use their arms and not be brushing their teeth and we run in because we think they're in VFib, okay? So that's kind of where these electrodes have kind of migrated up to, okay? Now we see them different places on the chest. Limb leads belong on the limbs, okay? So typically where I'll put them is I typically put them up here on the shoulders. Sometimes I put them on the triceps. But what you want to make sure that you do is you have them at the same place on both sides. Okay, same place. I don't want to put one here and then one here. I want them to be at the same place. Okay, I keep them off the chest. Chest is for the chest leads. Okay. Now the question always comes up, you know, and you get back to work and you're working with these very experienced paramedics and they go, that doesn't make a damn bit of difference, put it on. Okay? Well, the only thing that I argue with them is on one point. If I'm looking for STEMI, if I'm in the general area, it's going to pick it up. Okay? However, if I want some other very important information like axis measurements, PR intervals, QRS durations, QT intervals, all of those things, then lead placement is going to be important. Okay? So they're half correct with their statement. Okay? So when you're in the field and they say that, you can go, well, you're only half correct. Okay?
Evaluation is.
Yeah.
So up there on the front of the shoulder, is that?
You could
fit
do
on the
that.
chest?
Mm-hmm. Yeah. You could do that. But you want to, you know, put it on the muscle. If it's real bony, such as an old person, then you probably need to try and find a little bit of muscle because bone is going to help you with that artifact and all that. Okay? So this is our standard lead placement. Now we usually use what? White is right, smoke over fire. It's a great way to remember that, right? Okay? And then of course we have this fourth little lead down here. And this is either green or, well, it's usually green, right? But here's the thing. This green wire can go anywhere. It can go on their forehead. It can go on their big toe. It just needs to be grounded. That's all that it is. These three are critical where they go. These two need to be at the same spot. This guy can go anywhere. Okay? A ground is a ground is a ground is a ground. All right. So let's take the ground out for just a second. So we're going to kind of go through Einthoven's triangle. And the best way to probably start off with is lead 2 as we sit down here. Okay? And you're going to need to know these. You're going to need to know which one, you know, which directions they're looking. But with lead 2, what that tells me is that lead 2, the positive camera is going to be down here. Okay? And it's going to be looking towards this negative pole. Okay? This electrode. So it's going to be the camera and it's going to be looking up. Okay? So if you remember the electrical activity of the heart sits in here like this, right? The impulse moves its way this direction. Lead 2 sits right down here and gets the best glimpse, doesn't it?
So it's positive.
Mm-hmm. It's coming right towards it. So what I should see is I should see my P wave, nice and tall, which is the SA node firing off. And then I should see a nice QRS complex and then a nice T wave, right? Because I'm sitting down here and I'm seeing all of it with my camera. All right, so let's look over here with this lead 2. So this lead 2 is looking up this direction. I have my atria that fire off. Okay, it's working down to stuff the ventricles. The gatekeeper says, okay, come on through, hits the superhighway, depolarizes, and it's all caught. So I've got a nice tall R wave. Everybody see that? That's lead 2 of Einthoven's triangle. The next lead we'll talk about is lead 1. So here in lead 1, now the only 2 leads that apply are the left arm and the right arm. This guy doesn't even exist. Okay, bipolar means 2. This one and this one. Whereas lead 2 was this one and this one. Positive camera looking up this direction. Positive camera looking this direction. So if my camera is looking this direction, the electrical impulse fires off, sees it moving towards it, but it's not directly towards it, still catches it. How is it going to record it on EKG? Let's look over at lead 1. Sitting here, catches the P wave, my QRS, and my T wave. But what do you notice the difference in that R wave
Not
as
as big.
compared to this one?
Not as big,
And why is it not as big?
because it's not moving directly towards
Correct. It's all about the perspective. Still moving towards it, but not directly. All right? The last one in the triangle is lead 3. Lead 3, now we're back down to here. This is the positive camera, and now it's looking up here. Now my right arm has doesn't even exist. So now my camera is looking this direction, okay? The impulse is working this direction. It's not going towards it directly. It's coming this direction, so how is it going to see it? Almost the same as lead 1, right? Okay? So lead 3, sitting there looking this way, sees the P wave. It's a big bright flashlight, right? But my R wave is not as tall. You all see that. Everybody good? Okay. Let me test you. Put your thinking cap on for a second. Okay. With pregnancy, big gravida, let's say she's having 6 kids. Okay? And got this big old everything, you know? And so, because it's pushing the diaphragm up, tilts the heart. So the heart was like this, the electrical impulse moving this direction, but because of the pregnancy and the diaphragm, this all gets smushed and happens to tilt the heart a little bit. How do you think that changes 1, 2, and 3?
pretty good, I think. I mean,
Interesting.
you're gonna see one, lead two's not gonna be as prominent as
Okay, do you see how that changes? How's lead 1 going to look?
one's gonna look more like 2 with that big, with the nice big spike. in your
Right.
wave.
Okay, very good. And then what about lead 3?
It's gonna be more like lead 2 at that point.
Very good, because it's looking up this direction, isn't it? And it's seeing, perfect. You have the relationship between the perspective. Okay? Obesity has a tendency to rotate the heart.
With the with leads 2 and 3 be blended from all the because the babies, they have their own kind of contractility, don't they have heartbeats and stuff?
Yeah, but you won't, it's not going to pick that up. No, it won't. You'll still pick up the mom. Now you'll have to adjust where you put your electrode, but yeah. So my whole point of that was showing you that the axis had changed a little bit because of the physical positioning of the heart. Okay. Now what about you've got a 7-foot basketball player, big old tall basketball player, big lengthy chests. Their hearts tend to hang this direction. Okay? So again, as I'm coming down, how do you think that's going to do to the perspective? Lead 2 that's looking up, is it going to be tall?
Not quite, not as tall as it
Lead 3, am I almost going to be electrically silent?
Oh,
Because it's, I mean, it's essentially going to kind of be going this direction, and of course, so you see the relationship of the perspective, okay? So those are leads 1, 2, and 3. So in a normal axis, if the heart's coming down normally, leads 1, 2, and 3, everything should be upright. Everything should be nice and tall. Okay, lead 2 in normal conduction should be really nice and tall. Okay? Are you good with limb leads, the bipolar leads? Because now we're going to get into unipolar leads. Okay? So Dr. Einthoven continued to experiment. And so what he did is he had one positive wire, one positive electrode, but then he took two of his other, he took his other two wires and he basically spliced them together to one wire. So in this particular case, let me use AVF. Okay, he took the two arms, the left and the right, spliced them together with one wire, okay, and that made it augmented, okay, or averaged, okay. And he noticed he got a different look with that. So first of all, AVR is right arm. Think of the right, that last letter. AVL, think of left arm. And what do you think F is? Foot. AVF. Foot. Okay. So using the same four leads, these are again called limb leads. They're just they're unipolar, not bipolar. So we've covered Einthoven's triangle. All right. Now we're talking about the augmented leads, AVL, AVR, and AVF. Okay. So let's talk about AVF because it's the easiest one to understand. All right. AVF, where's the positive camera? The foot. Okay. The last letter indicates the positive camera, the one that's looking, the positive pole. So AVF is sitting down here. These two have been augmented. They had by splicing them together, it is looking up here about the AV node. Okay? This is its reference point. So the camera's looking up, sees the impulses all firing off, still moving in its general direction. So how is it going to record it?
Go up.
Yep. So just like lead 2, right? So when you look at AVF and lead 2, they look pretty close. They look really similar because they sit right in the driver's seat and look at the impulse moving right towards it. All right, let's talk about AVL. So AVL, where's my positive camera? Left. Left arm, very good. And so my left arm is here. These two are averaged. It's looking this direction. Now this camera is looking down here, just like this. The impulse is moving like this. So how is it going to see it?
Almost like crisscross, or not crisscross, but like almost,
You're right.
I can't think of the word.
Is it going to be real tall?
No.
Okay.
It's going to be silent.
It almost electrically silent because it's not moving towards it or away from it. It's going right by it. Okay. And so it may just be a little bit of bump. So usually with like lead AVF, where's this? I may have this. So where's lead AVF is here, that R wave is up, and AVL we may just have a little bitty nothing. Because it's not really seeing it. It's just kind of going by it. All right? And then the last one is AVR. AVR is kind of cool. Because AVR, this is the only time that this electrode really gets to be a positive camera. So AVR, this is a positive camera. It's sitting right here. AVL and AVF are augmented, so it's looking this direction. This camera is looking right here. The impulse fires off. Everything is moving this direction. So how is it seeing it?
So now it's going in reverse.
Okay, and so what is it going to do to the complexes?
Here.
It's going to drop everything. Because all it sees is it sees it. It goes, but this is going away from me. Okay? So let's take a look at this. So AVR, the P wave is down because it saw the atrial depolarization, but it was moving away. My ventricular depolarization is all seen because it's moving away, and my repolarization is all seen because it's moving away. So that's why it dropped it.
So it's just pretty much a reverse. I mean, AVF and AVR are gonna almost look opposite
Yes.
When they're,
I mean, they're pretty much
I
are.
mean, yeah, it makes sense, because they're at opposite.
They're on
contours,
opposite,
really.
yeah, opposite.
Very good. So when we read an EKG, when we read a 12 lead, it looks like this, okay? Okay, so we know in lead 1, everything's going to be upright, right? We know lead 2, everything's going to be upright, but my R wave is going to be a little bit bigger on a normal axis, right? And then in lead 3, we know it's going to be upright, but not as tall as lead 2. Okay? Now, this is in healthy, normal conduction. If we were to do 12 leads on you, you would probably all have a variance to this. It's just normal. Okay? Now, AVR, as we said before, everything is going to be down. Right? AVF, everything's going to be upright because they're opposite, exactly what you said. And then what did we know about AVL?
Almost silent.
Really nothing. And so the way I teach it is I say AVL, think of it as being smashed between AVR and AVF. Think of it being sandwiched and smashed between those. Okay? These are called limb leads. Okay? These are called precordial leads, or our chest leads. Okay? These are bipolar, meaning one positive and one negative. And then these are unipolar, with one positive and two negatives that are averaged. Okay? So 3 poles. How are we doing? You okay? Good? Giving them a view of that. Okay, so we've covered the limb leads. So again, the limb leads belong on the limbs, up on the shoulders and stuff. So the next one we'll talk about are the chest leads. So Dr. Einthoven thought, well, there's still got to be more to this, being able to measure the heart's electrical impulse. And so what he did is he started putting suction cups on the chest wall. Okay? Started putting suction cups on the chest wall, and he noticed that as I move these things around, I see a little bit of a difference in the way the impulse is read, or the impulse is seen. Okay? And so these are our modern precordial leads that we talk about today. So what he did is he had his limb leads come in, and then he basically took off that lower, what would be the left leg, and moved it up and made an adjustment in his machine. Those are called modified chest leads, by the way. There are people who still utilize that today. Okay? And then so by moving that around, he was able to take a look at that. So what I have here is on the mannequin is I have the standard 12 lead placement, yeah, maybe these are a little bit too high, maybe should come down, but you get the general idea. And so what we have here is we have our V1, our V2, V3, V4, V5, and V6. 6 precordial or 6 chest leads, okay? V1, 2, 3, 4, 5, and 6, okay? Now, we'll talk about placement and skin prep and all that. But what I want you to do is I want you to imagine where the heart is and how it's placed under here, okay? Now, the precordial leads, they actually look at the chest on a horizontal view versus a vertical view. So a 12 lead, by looking at both the limb leads and the precordial leads, give us this kind of a view of the heart. So we see it from the front, and then we see it in a sliced view. So we're able to really see the behavior within all of those tissues from a couple of different things. Now, with that said, with the heart sitting here, V1, when it records, how much of this impulse is it really going to see coming towards it? Yeah, not a whole lot, right? But as I move around to V2, V3, V4, V5, V6, by the time I'm hitting V6, I'm looking this direction, I should be seeing more of the complexes, right? Okay, so coming up to the screen, we notice here in V1, we notice that the R wave is really, really small, okay? And then as we move by V6, it should be nice and tall, okay? That's called R wave progression, and it makes sense if you understand where the camera is, where it's looking, and why we, and how each time that the lead moves across, it gets bigger. So V1, I should have a real small R wave. V2, I should have a little bigger. V3, bigger yet. V4, bigger yet. V5, I should almost be fully upright, and 6, certainly fully upright. So think about that with the precordial leads. It's called R wave progression. Think about a seed. You plant a seed. So each one of these represents, a month in time or something. So my seed is up a little bit. By month 2, it's growing a little bit more. Month 3, month 4, month 5, month 6. So I should see that R wave progression as I move up. Okay? Now, folks, what I've shown you here is a normal 12 lead. Okay? Is a 12 lead. Now what we do much later, after we recognize, because I can teach you right now how to read for STEMI and read for some of those other things. That's easy. And I can teach you to go 2, 3 AVF, look at the inferior wall, 1 and 2, 3 and 4 are anterior, 5 and 6 and 1 in AVL are lateral. That's easy, that's memorization. And we'll get to that. But first we have to understand what the underlying rhythm is. Are we normal sinus, atrial fib, atrial flutter, junctional rhythm, whatever it may be? That's our next chore, that's where we're going to get to. But once we get through all that, then we'll come back to this and we'll start localizing some more of this stuff. All right, so any questions with the precordial leads? So we will come back and we will visit what a normal 12 lead looks like.
Where is the positive and negative? Are they polar? Like what direction is V1 through V6 looking from? Are they still?
It's looking straight in.
Okay, so it's going.
It's going straight in
Okay.
versus this direction.
Okay.
It's going straight in to the AV node. So here shows R wave progression. Do you see that? R wave is small as I move to V2, V3, V4, V5, V6. Should be fully upright. Any question? We good? We good?
So the S wave is
That's why
just
V6 is way back here.
in
So
reverse.
it looks straight in.
because
I
it's
got
looking
you.
at it going away.
Yes.
Like directly.
You got it. You got it. All right, what I want to point out here is there are lots of reasons for dysrhythmia. So what is a dysrhythmia? By definition, a dysrhythmia would be something that is what? Not normal, okay? Basically not normal or varying from what's normal dysrhythmia. And so there's lots of things. MI can cause it, ischemia can cause it, heart disease, vagal tone, drugs, hypothermia, metabolic imbalance. Coming back to metabolic imbalance, knowing what you know about the sodium and the potassium pumps,